Yeah, welcome tonight to our review of endodontic diagnosis and treatment planning. I appreciate your being with us here on Viva Learning. And I'm Dr. Rich Mounts. And the time that we have together today, I would like to focus on a aspect of endodontics that is critical to restorative dentistry and endodontics in particular, and really is the foundation of restorative treatment. And my goal is to provide you evidence-based and clinically relevant information that you can take into the operatory tomorrow. Quite a bit of what we're going to talk about is based on the PDF, which is on the lower right-hand side of your screen, which is the Colleagues for Excellence that was published by the American Association of Endodontists. This is an excellent resource. If you'd like a copy of it, I'd be happy to email you a PDF. My email will come up again at the end of the presentation, and feel free to write me with questions, or I can send you this free, of course. And this will help re-emphasize or emphasize some of the material we're going to cover today. By way of introduction, I graduated from my endo program, Oregon, in 1991, and currently I practice endodontics in Eagle River, Alaska. I've been there for the last 5.5 years, and I'm a practicing endodontist, and I have no commercial influences, conflicts, or disclosures to make because I don't have any contracts with anyone. So what you're going to hear is a completely unbiased presentation. So before we get right into diagnosis, I want to address two very common clinical questions. We started the last presentation that we did 2 weeks ago with some clinical common questions. Let's talk about how we anesthetize the hot lower molar. And so first off, I think it's important that we come to grips with the concept that getting people numb for endodontics is inherently different and more challenging than it would be for restorative treatment. So we need a different mindset, and we need a different approach from a crown prep versus a tooth that's been keeping someone up at night for quite a while. Maybe they're phobic, maybe they waited, and now the tooth has kind of brewed itself or festered into something that's really uncomfortable now in a phobic patient, and maybe this was the reason they delayed treatment. So I will first off give a block. It's generally lidocaine. I will wait about 5 minutes. Then I will give an articaine infiltration, and I'll wait a few more minutes, and then I use articaine as a block. I'm very comfortable with that. So now at this point, the patient's had 3 cartridges over about a 15-minute period. And then I will give them a PDL, both mesial and distal. I will also infiltrate on the lingual. If they are not profoundly numb at this point, then I will use intraosseous in the form of the X-tip, which is a Dentsply product. And 99.999% of the time, then the patient is profoundly numb. One of the things it's important to briefly mention is that, tell the patient this is going to take a little bit of time, set their expectations, tell them you're going to get them profoundly numb before you start anything, and that you're going to get them numb as gently as possible. And I found that, giving patients that reassurance and then approaching it with the expectation that it might take a little bit of time really has paid dividends. So that's my technique. There are a few potential alterations in that, but for the average lower molar that is severely, irreversibly inflamed and painful, that's what I will do. When do you prescribe antibiotics? The only time really that I prescribe antibiotics is in the presence of a fluctuant swelling. I don't routinely prescribe antibiotics for pain in and of itself in the absence of swelling. So the patient needs a fluctuant swelling for me to prescribe antibiotics. And I think if you read the literature and you read the recommendations from the American Association of Endodontics, they will emphasize the critical nature of only prescribing antibiotics in the presence of a fluctuant swelling. We don't want to enhance the growth of resistant antibiotics through their overuse. And one way to preserve the antibiotics we have is to use them when they're really needed. So treatment planning wise, we need to, from an endodontic viewpoint, assess the risk, assess our resources, assess our skills. We make a plan and we make a definitive pulpal and periapical diagnosis. To put that in different words, we do not embark on endodontic treatment. We don't pick up the handpiece. We don't pick up the syringe unless we've done the appropriate clinical testing, which we're going to get into in a minute. And then we have made a definitive pulpal and periapical diagnosis based on the clinical exam, the patient history, and then some input from the radiographic findings that we have. And we're going to get into the weeds on this in a very clear way here very shortly. But the point is, we have to know what that pulpal diagnosis is and what that periapical diagnosis is. And I've mentioned in other podcasts and other presentations, I do expert witness work. I can tell you that in virtually almost every case, without exception, that results in a malpractice claim, one of many pieces of different scenarios is the lack of a pulpal and a periapical diagnosis. And most often and almost virtually always, be careful with always and never, but there's a lack of a comprehensive examination of the sort that we're going to be talking about. So as we are taking the patient history and we're listening and gathering information, have we duplicated the patient's chief complaints? The patient says it hurts to cold. Well, did we test the teeth to cold? The patient says it hurts to chew. Well, did we do proper percussion testing on those teeth? Have we duplicated their chief complaint? Have we asked some critical questions? And those critical questions are, is this tooth restorable? Is it strategic? Is it worth doing a root canal? And are we going to benefit this patient by doing this procedure? Are they going to be in a dentally superior position aside from just potentially, got a hammer, got a nail, need to do a root canal, got to pound that nail? And then we have to ask ourselves, are we the best person to treat this individual? Are we the best clinician under the circumstances, given this person's needs, and consider referral? So can I treat this case? Do I have the skills? Do I have the time? Do I have the equipment? Do I have the staff backup? Do I have everything I need to treat this person optimally? And if we don't, then that is a case that could be, should be, and optimally is referred to someone who has the time, has the skills, and has the equipment. And I like to think of this as the harbingers of misadventure, which is this sort of spacious idea, but I just think X. I just think about this, about root canals, or I just think that I want to try it, or, I just think that this is the tooth that needs to be done. No, we have to have the right information, the right examination, the right radiographic interpretation. We need to have a conversation with the patient that they're on board to do this, and we need to inform before we perform. And, there is this, I don't see anything on the x-ray. Well, unless there is a lesion where the cortical plate, in two-dimensional x-rays, the cortical plate has been eroded, or we have a cone beam and we can see the lesion on the cone beam, radiographs are not going to be valuable in the early stages of endodontic disease. And so we're not going to see in an irreversible pulpitis bony changes. So the idea that you don't see anything on an x-ray is really irrelevant to the question of whether that patient needs a root canal for irreversible pulpitis that's symptomatic or asymptomatic. We're not going to see radiographic changes until later in the process. Then we're going to get into the conversation about, well, it doesn't hurt, so let's just watch it. And that potentially causes all manner of different problems. The patient either has an irreversible pulpitis that is symptomatic or asymptomatic, or they don't. And relatively rarely is it gray. And if we're really truthful and thorough and we exhibit methodical skepticism, we're going to be able to tell whether that patient needs a root canal or not. But the idea of watching and waiting in the presence of symptoms, or when the patient clearly needs a root canal based on an irreversible pulpitis, is really never in the patient's best interest. So we want to be aware of the clinical situation and be intimately familiar with what's happening. But waiting and watching is many times counterproductive for reasons we're going to talk about. So what are some cases that are the harbingers of misadventure? This lower anterior had been traumatized. You can tell by the widening of the periodontal ligament, but this open apex, assuming that, this tooth is vital, this open apex has all kinds of clinical complications that are possible based on the fact that there's not a mature apex. So do we have the skills, the ability, the knowledge, how to treat this, diagnose this? If we don't, the worst case scenario is we open up this pulp chamber without a diagnosis, take out the pulp, and then refer it to an endodontist and expect them to then kind of pull this out of the fire. This is a case that optimally, unless you have a significant literature base and a lot of experience treating this kind of trauma, that would best be referred. This tooth, number 3 in this picture, we can't see the pulp chamber. We can't see any canals in the roots. Admittedly, this is a 2D picture, but we would want a cone beam. And we want to see, is there a 4th canal? And how small are the main canals in this tooth? And then we would have to know that accessing through that amount of porcelain, through that amount of metal, looking for the pulp chamber in a non-vital tooth is going to be really clinically challenging. If we don't have a microscope and we don't have the knowledge of the anatomy and we don't have the skills, this could easily turn into a perforation. And looking at this lower bicuspid, we have a 2 or 3 rooted lower bicuspid. You can see in number 21 where they were not able to stay in line with the canal and go around the curve, and they ended up with a perforation, which ultimately failed. And now that would require some form of surgery if that is possible in terms of what the restorability of that tooth in 21 would be later. But for number 20, that is a clinically really difficult Himalayan mountain type of clinical case. This is not the case that we would want to jump into and hope that we're going to be able to negotiate the different canal systems. But at its basis, we would need a cone beam in order to determine 2 roots or 3, where those canals are, what the estimated working length is, how many millimeters down before we're going to see the divide. Do we have a microscope to be able to see the divide? So we really need to look very carefully at these cases to get an idea how complicated they are, and then make that gut decision. Yeah, I'm the best person to take care of this case, or no, I'm not, and I need to refer. So when do you need a cone beam? Why do you need a cone beam? And how do you read the cone beam? So we could talk for hours about cone beam technology. But one of the huge benefits of cone beam is to know the anatomy that we're up against, meaning both the canal anatomy, the root anatomy, and whether there's pathology, whatever that is, and where the anatomic structures are in relation to the teeth. So if you look at both sides of this cone beam slice, and you can see the inferior alveolar nerve canal, which is right continuous with the apex. And I can tell you as an expert witness that I have seen a plethora, which means a whole lot of cases in the past year, 2 years, 3 years, where people have violated the apical constriction and not appreciating the viscosity, the flowability of sealer of calcium hydroxide, and poured sealer and calcium hydroxide into the mandibular canal. So if you're going to do molar root canal, especially in the lower arch, we need to be intimately involved with thinking about, aware of, where is the inferior alveolar canal? Well, there's no better way to know that than through a very careful evaluation of the position of the mandibular canal in relation to the root apices. So here's another view, different tooth. And, if you over-instrumented that tooth and you get profuse bleeding, you need the light bulb to go off to say, I'm long, or I've got tissue potentially still in the canal, but I may not be where I think I am at the tip of the root. And we need to stop and then figure out exactly where that root apex is, because we must, and I want to emphasize the word must, keep our instrumentation, our irrigation, our obturation materials inside the tooth at the very most apical level at the minor constriction and potentially slightly back from that. But the important part for this part of our conversation relative to cone beam is cone beam will be your very best friend in terms of telling you where the minor constriction, the root apex is in relation to this structure, the mandibular canal, and the mental nerve. So to arrive at an endodontic diagnosis, the clinical examination and the information we need is realistically, we should have two periapical pictures, two-dimensional pictures. And, is it malpractice if you don't have two? No. If you have one diagnostic PA, are you within the standard of care? Yes. Is it optimal? Is it the standard of practice? That's a different question. I think it's better to have two PAs, but some of this might get a little gray from a legal perspective. But having two PAs is optimal. Having a cone beam, when you need it, you need it. And if you have any question related to atypical anatomy or anatomical structures, you need it. And we need to record percussion, palpation, mobility, probings on the offending tooth, as well as control teeth. In other words, if we're going to percuss and palpate and do these things, we need to do that on the tooth we're suspicious of, but also the other teeth around it, as well as the contralateral tooth, with the knowledge that we're trying to differentiate our findings on the tooth we suspect versus the other teeth around our offending suspect, so to speak. We need thermal and electrical testing. That could be hot. It most certainly is always cold. It could be potentially electric testing. And we need to do that again on the offending tooth, the adjacent teeth, and maybe even all the teeth in the quadrant and the contralateral tooth to see the difference between the tooth that we're looking at and the other teeth around it. And, having fiber optic illumination, looking at cracks and seeing how far that crack goes and whether there are coronal fractures and how severe they are, that has benefit. Having a tooth sleuth, plastic bite stick, to see if they have pain upon release on the various cusps of a tooth can be really helpful. And sometimes we need a test cavity, which is fairly rare, but occasionally we need it. And then selective anesthesia, trying to rule out a case of referred pain. Maybe the tooth is sensitive to percussion on number 3, but maybe the patient swears it's number 30. And the patient says, "Doc, I am sure it is in the lower arch. I'm sure it's a lower tooth, but you do all of your testing. There's nothing in the lower arch that stands out, but you percuss number 3. They jump. They say it feels different. If you anesthetize number 3 and then the pain goes away and all the pain is gone, then that selective anesthesia can be beneficial. Sometimes you might be doing a PDL and trying to numb just one tooth without a regional or an infiltration. Depends on the particular case, but we want to keep that in our arsenal of tests. This is from the Colleagues for Excellence from the AAE that I referred to in one of the opening slides from 2013. As I said, if you want this document, it's an excellent guide to diagnosis and treatment planning. Email me and I'll be happy to send it to you. But this, in a grid format, presents to you essentially what I've said so far. We're taking the medical and dental history. We know what their recent treatment was. If the crown was put on 2 months ago, we need to know that. If it's been 5 years since the patient's had treatment, then that may lead us to potentially less of a specific location for the pain, as opposed to I had a crown on number 30 a month ago, and now I can't chew on number 30. But we need to record the chief complaint. How long has this been going on? What are the symptoms? How long does it last? Where does it start? What makes it start? Is it just very sharp or is it dull? How long? Does this last for hours, for minutes? When I drink cold, it lingers, it doesn't linger, those types of things. And facial asymmetries. Is there a sinus tract? All of these things, is there caries? How many restorations do we have? What's the probing? All of these things are pieces of evidence that collectively, when we record them in a grid format in our charting, will slowly build the case that we have the correct tooth. And we need thermal testing, whether that's hot, cold, potentially electric. We need to be able to perform those with confidence and know what those are telling us. So if we test number 29 and they feel the cold and it goes away, we test 31, they feel the cold and it goes away. We put the cold on 30 and they don't feel anything. And their pain is a dull pain that is centered around number 30. That's a bingo. That's number 30. It's a non-vital pulp or a partially necrotic pulp that needs attention. And so we're also going to test percussion, palpation. The value of knowing whether the tooth is percussion sensitive is it tells us whether there's inflammation in the bone, and palpation sensitivity tells us the degree of apical inflammation and how far and wide that inflammation has spread. So sometimes you'll have a tooth that's sensitive to percussion, but not to palpation. Or if you have both, then you know that this is a more long-standing condition. So realistically, we want at least 2 periapicals, maybe a bite wing to see what the restorative status is there decay, and then CBCT when we need it. Now, some endodontists will say, I always take CBCT on every case, every patient, every time, and I don't have any problem with that. And the alternative is to take CBCT when you need it. And I don't have any problem with that either. So I take CBCT when I need it. I don't do it every case, but if I have any inclination that the cone beam will give me information, I'm going to take a cone beam first. Now, I'm a general dentist. Let's change the scenario. I'm an endodontist, but let's say I'm a general dentist. I don't know that you need a cone beam in your office, but you need a cone beam available to you when you need it. In other words, if you're going to do second molar endo and you don't have a cone beam and you don't have access to a cone beam and you get into trouble, that's problematic. So you need to know where that mandibular bundle is in relation to the root apex, and having the availability to you of a cone beam is obviously really important. So we mentioned transillumination, selective anesthesia, and a test cavity. Those are relatively uncommon, but at times they are helpful. So we're always going to derive for the patient prior to treatment a pulpal and a periapical diagnosis. And when we're in doubt, we don't know, we're not sure for whatever reason, you should refer the case and or observe the patient and reevaluate them. So another way of saying that is when you are in doubt and you are not sure, there is power in either referring them or bringing them back the next day and the day after that and the day after that until you are absolutely certain about what's going on. You do not ever want to be in a situation where you are playing roulette with other people's teeth, hoping that you have the right tooth. So if you can't duplicate the chief complaint and you can't derive a pulpal and periapical diagnosis, you need to punt and either refer it or wait until you're sure. So what's the duration? What's the intensity? What caused the pain? What's the frequency of the pain? What medications are they taking? Are they swollen? And the longer the pain, the more intense, the more frequent the pain, the more medications they're taking, the more likely it becomes that this is an irreversible situation that requires root canal treatment. And when they have swelling of endodontic origin, obviously, that's going to be a non-vital situation where they need endodontic treatment. And then in terms of interpreting the radiographs, what is the bone status? What's the periapical status of the bony tissues? Do you have a periapical radiolucency? Do you have a widened PDL? Is it within normal limits? So in other words, if you have percussion sensitivity and a widened PDL and a hyper-responsive pulp to cold, that is one of the trifectas of clinical evidence that we have an irreversible pulpitis. Or if we have a periapical radiolucency with no response to cold, and potentially we have dull pain and sensitivity to percussion, those are cardinal signs of a non-vital tooth that is becoming symptomatic. And we take CBCT when we need it. So if our 2D pictures are not clear, or for whatever reason we can't see the information we need, then we need a cone beam, which allows us this three-dimensional evaluation of the treatment. Now, I know some doctors, and I don't want to name names, obviously I wouldn't, who don't take cone beams because they don't want the legal liability of reading that cone beam. And literally, those doctors are putting their heads in the sand in terms of not knowing, so somehow they can't be held accountable. And I'm 180 degrees against that philosophy. We go take a course, buy the cone beam, or get the cone beam, or send it to beam readers, but have somebody read the cone beam if you don't want the liability for the cone beam. But when you need it and there's uncertainty, you really need it. And I don't really believe you should be doing lower molar teeth in the absence of a cone beam, especially if there's any semblance of complication to the particular anatomy, meaning long roots, curved roots, a lower second molar that has one root, one large canal with a big foramen. Those are all setups for potential severe complications. But what's really important to us is we should never rely on radiographs alone. Just saying, well, I don't see anything on the radiograph. Well, that's not really material to the diagnosis necessarily. It's not a primary piece of evidence. What's the clinical history? What's the patient's chief complaint? What are these, the percussion, the palpation, the mobility, the probings, the cold testing? What's the comprehensive clinical picture? And we need to duplicate that chief complaint or delay the treatment or refer it. What's the perio status? Is it restorable? Is there a potential non-odontogenic pain source? If we have a patient's chief complaint that doesn't sound right, look right, we can't duplicate the chief complaint. The patient says this same issue has been happening for years, or potentially they describe it as an electric shock or a lightning bolt, or it feels like I've got a live wire in my tooth. Those kinds of descriptors are non-odontogenic descriptors. And we need to be able to differentiate between a non-odontogenic pain source, meaning an atypical facial pain, a TMJ, a trigeminal neuralgia. We need to be able to differentiate between those and that which is purely odontogenically generated. Does the tooth have significant fractures? The bigger the fillings, the deeper the fillings, the more the decay, the more significant the fractures. All of these findings would emphasize the potential for an irreversibly inflamed or non-vital pulp. And when we have conflicting evidence, then we want to step back, consider everything in its totality, and then with methodical skepticism, we want to consider referral, potentially even to a pain clinic when we think it might be a non-odontogenic pain source. So we have basically a number of pulpal diagnoses, and they range from normal to reversible pulpitis to symptomatic irreversible, asymptomatic irreversible, a necrotic pulp, a previously completed treatment, and then a previously initiated treatment. So we're not going to describe a normal pulp because I think everybody knows what that is, but a symptomatic irreversible pulpitis is sharp, it's lingering to hot or cold, it can be unprovoked, and or it can be referred. Unprovoked means spontaneous. It means nocturnal. It means it wakes them up from sleep. It means that you don't necessarily have to do anything to make that tooth starts to hurt. It just starts to hurt on its own, or potentially the stimuli is hot or cold, and it will not get better. And so very briefly, I use the basketball court analogy, and I say to the patient, listen, on one left side of the court, there's a brand new healthy pulp that's perfectly fine. On the far end of the court, there's a dead pulp and a dead nerve. And in the middle at the half court line, there's an irreversibly inflamed nerve that will not get better. And once you cross over that line, you cannot go back to a healthy pulp. In other words, that tooth is traumatized enough, the nerve is unhealthy enough, it has absorbed enough toxicity, trauma, heating, cooling, lack of blood flow, etc., it is not going to heal. It is going to die. And your tooth has crossed over the line. And the choice you then have to make is, do you want to save the tooth through a root canal, or do you want the tooth extracted? And that really frames the conversation in a way that they can appreciate what's going on. But the inflammation in this diagnosis has not reached the periapical tissues, which is why you don't see a lesion. So when you look at number 4, huge filling right on top of the pulp, it probably was a direct pulp cap. There's also a filling to the mesial, and potentially there's recurrent decay there as well. I don't know, but there's definitely a base under the distal. This tooth is severely traumatized, and I would expect in this particular case, we don't see a lesion. Maybe there's a little bit of percussion sensitivity, but fundamentally, this has the radiographic hallmarks of a tooth that should be irreversibly inflamed, but then we duplicate the chief complaint. So asymptomatic irreversible pulpitis is another way of saying you have an irreversibly inflamed nerve. It's not going to heal. It's asymptomatic. It may even have a normal response to cold testing, but you have deep caries that are likely to result in exposure following removal. And so this was a case of an upper molar. The tooth had really deep cervical class 5 caries. This filling was put in. This filling was put directly on top and partially into the mesiobuccal root and the canal, and then the patient became symptomatic. I would suggest to you, looking at that radiograph, that this initially needed root canal treatment prior to the filling. And probably what happened was the doctor just didn't want to tell the patient the bad news. I think we need to root canal this before we restore this tooth. So that was an asymptomatic case. Here's a case where once we get all that decay out, and given the placement of the lesion, the size of the lesion, the widening of the PDL apically, it's asymptomatic. We need that wisdom tooth removed, but we also need endo on that tooth, and there's the final treatment. Okay, so from the Journal of Endodontics this year in 22, one of the findings of this study was multiple restorations at the time we cement a crown is identified as a significant predictive factor for the need for endodontic treatment after crown cementation in teeth with no pre-existing questionable or confirmed endodontic disease. Translated, the more fillings you have when you crown a tooth, the greater the chance that tooth is going to need a root canal. So we want to be looking at these teeth that are asymptomatic, where we don't see anything on the radiograph, and we want to be having a conversation with the patient and saying, hey, Mrs. Smith, if we do the root canal on this tooth, we very easily could end up you having symptoms starting tomorrow. And, we need to be aware that this is a risk. Do you want to consider the conversation about having a root canal, or making the direct recommendation they have the root canal so we don't cement the crown and then find out later where we have to drill through the crown in order to do the root canal, where we could have done the root canal first and then cement their crown. And from that same study, clinicians should be aware and inform patients about the increased risk of endodontic treatment need with a history of more than one restoration, especially during the first 3 years after permanent crown cementation, which is another way of saying inform before you perform. So pulp necrosis as a diagnosis is the death of the pulp. It's non-responsive to pulp testing. In my hands, that's generally cold. Generally, this is asymptomatic, and some teeth may be non-responsive to pulp testing because they're calcified, they have recent trauma, or they simply don't respond. So those are the pulpal diagnoses. Let's talk about the apical, the periapical diagnosis. We can have normal apical tissues, symptomatic apical periodontitis. It can be asymptomatic, chronic apical abscess, or acute apical abscess. So we're going to drill down and define each of these. So normal tissues have no sensitivity to percussion or palpation. The periapex is radiographically normal. And we do comparative testing for percussion and palpation and thermal testing. And that should always begin with normal teeth as a baseline. Symptomatic apical periodontitis, the apical periodontium, meaning the tissue, the bony tissues at the root apex are inflamed. And the inflammatory mediators are in the process of inflammation is taking place at the apical area, and it's painful to bite on, and or they have pain to percussion or palpation. And then they may or may not have radiographic changes. And whether they have radiographic changes or not partially depends on whether we're using CBCT or 2D pictures, with the CBCT being much, much more sensitive. But this condition can also have severe pain to percussion and or to palpation. So here we go. Tooth number 30 was severely percussion sensitive, apical inflammation, widened PDL on both the mesial and the distal roots on 30. And there's the final treatment, and the patient symptoms resolved immediately. So asymptomatic apical periodontitis means we have destruction and inflammation of pulpal origin at the apex, and we have a radiolucency apically without clinical symptoms. So here's a case in point, tooth number 30, lower right side, obviously, 2 lesions, mesial and distal, was asymptomatic. And there's the final treatment, 2 canals in the distal. So we're always looking for 2 canals in the distal. Actually, we should be looking for 3, and it's rare to have 4, but you can. But we always want to be looking for that middle mesial canal, both in the distal and in the mesial roots of lower molars. Let me say that again. Mesial roots of lower molars, about 15 to 30% of the time, there is a middle mesial, and there can be 3 canals in the distal. And you're not going to find it if you don't look for it. So we need to be looking for it. Okay, chronic apical abscess. Pulpal infection and necrosis characterized by gradual onset, very little discomfort, intermittent discharge through an associated sinus tract. So essentially, if you have a parulus or you have a chronic sinus stoma and we have drainage, that is like a pressure cooker that has the relief valve open, and the pus and the pressure and the inflammation and the mediators and the toxins, essentially in the form of pus, that's all bacteria, is all being released through that sinus tract, which keeps that essentially asymptomatic until that tract closes. And that's when the patient is going to swell, and we're going to have significant symptoms that become manifest. So typically there is a radiolucency, and we want to track these with gutta-percha, which will give us a very clear idea which tooth and which lesion is the source of the fistula. An acute apical abscess is a periapical infection in the necrotic pulp. It can have a very rapid onset. There's spontaneous pain. The tooth is extremely tender to touch, which means to pressure. We have pus and swelling of the tissues. And, radiographically, there may not be any signs of destruction, and the patient obviously can often experience malaise, fever, and lymphadenopathy. So in other words, this is the tooth where we may not have any radiographic changes, but they're swollen up like a balloon, and we need that tooth opened up, IND, antibiotics, or potentially, if they don't want a root canal or the tooth is not restorable, that tooth needs extraction ASAP to relieve that. So here's a case in point. There was swelling, rapid swelling that occurred quickly, and we opened the tooth up, treated the root canal space, and there was gradual resolution. Okay, so in the big picture, we want to build a case for treatment, observation, or for referral. But we want to avoid living in what I call living in a land called hope, where we adjust the occlusion, we call it bruxism, we delay the root canal in the presence of clear symptoms or indication, and we're just kind of kicking the can down the road, and we're not getting to the heart of the question, and we just don't want to give the patient a bad news. That is contraindicated and not in anyone's best interest. So if they have the signs and symptoms of an irreversible problem, meaning they need a root canal, we need to tell them, we need to see it, we need to diagnose it, we need to look for it, and then give them their options. So let's look at a couple of cases really quickly. In this case, on day 1, patient came in and chief complaint, there in the findings, the temperature and they had temperature and they had thermal pain. That was their chief complaint in the upper right. So they can't drink cold, and so it was temperature sensitive in the upper right side. Now, all the findings were within normal limits. There were deep restorations on 3 and 4, percussion, palpation, mobility, probing, cold testing on 3 and 4. Everything was normal. I couldn't duplicate the chief complaint. So the next day I had him come back, and now number 4 has severe percussion sensitivity. It has no response to cold, even though the day before it was normal to cold. And the tooth was partially necrotic upon access. So I couldn't duplicate the cold sensitivity on day 1 and their chief complaint. We delayed, we waited. Next day, went back through the testing, and it was number 4. So here's an interesting case. On number 11, the tooth is, according to the patient, is turning slightly dark, and the patient has a cold test initially, and initially there's no response to cold. So I was called into the room, take a look at things. I test them to cold 10 minutes later, and basically, things are normal. And so was it vital or non-vital? Well, because on the second test, we got a normal response, and radiographically, there is no signs or symptoms. And it turned out that the darkness the patient was reporting was more of an aesthetic darkness related to staining, not from a non-vital tooth. We delayed, and no treatment was rendered in that particular case. So here's an interesting case. What's the pulpal status at number 12 with that implant? And is that resorption? So I would suggest to you, when you see something like this, where an implant was put into a space that obviously was not adequate, that we may have resorption. This is where we need a cone beam. This is cold testing, percussion, palpation, mobility, probings. We need to tell the patient what the prognosis is of this tooth. And I will tell you the long-term prognosis of number 12 is not particularly good. So very briefly, I want to talk to you about non-odontogenic pain. And we need a thorough history that takes into account all of these various factors: location, onset, quality, frequency, duration, the severity. Is it getting better, getting worse? What symptoms do we have? I want to acknowledge Tom Shackleton up in Calgary, Canada, gave me these slides. But what's important is that you're not on your own in these. This is where we need an endodontist. Maybe we need an oral facial pain, oral medicine specialist to get involved. Is it TMD? Is it trigeminal neuralgia? What exactly is happening? And if we have signs and symptoms where we can't localize the pain into a typical endodontic, reproducible a set of signs and symptoms, we need to step back, take a breath, bring our colleagues in, and try to sort out what's really going on. So let's say we've made our diagnosis. Now what? Let's talk some clinical tips. I would suggest to you, and some of this is going to be a very brief review of what we talked about in the last state-of-the-art lecture, but let's briefly touch on it. The smaller the access, the more dentin we can preserve while maintaining visual and tactile control, the better. So if we want to get, in this access, which came from Dr. Boveda, we can irrigate this. We can instrument this. We can see the canals. We have control over our files. We have control over the hand files, over the rotary files. Visually through a microscope, that's more than enough room to be able to work. We want to be aware of the size of our shapes. In other words, if we take the canal space to the size of an 0430, let's say at a max, and we activate our irrigation sonically, ultrasonically, potentially with lasers, gentle wave, a number of different mechanical means to optimize our irrigation. We optimize the volume of irrigation, the refreshment of the irrigation, the type of irrigation we use, meaning both EDTA liquid as well as full strength bleach. If we optimize that, we don't need to have massive shapes. So in other words, my point to you is the idea that we have to take a lot of dentin away in order to properly clean the canals is false thinking. We need a shape that's big enough to irrigate, to be able to instrument, to irrigate, to activate our irrigation, to fit a cone and obturate, and that's as big as it needs to be. So we want to preserve dentin with the goal of maintaining tooth structure. So one of the ways to locate canals, especially in a calcified situation, is to have an ultrasonic unit. I have no contract or incentive through NSK or Tune or anybody else. I really like this Varios unit, the 970. It has multiple water reservoirs. It has a light source in the handpiece. This can be used for scaling in hygiene, for restorative dentistry, for endodontics, for endodontic surgery, periodontal needs. It is a multifunctional device across a lot of platforms. And one of the things I really like about this, and again, I have no incentive to sell anybody anything. What I really like about this is the power settings really are different depending on when you take it from a 7 to an 8 or a 4 to a 5. It's really different. So I'm a guitar guy, and some of the guitars, you can't really tell the difference between the different tone knobs or the different selector switches in terms of how sensitive the guitar is going to be. And in other guitars, higher end guitars, you can really tell the difference. Well, this unit's like that. As the power goes up, you have more control. We don't have time to get into a long description of hand files. And again, no contact commercially with Monty. But if anybody wants to talk or get more information about hand files for today's lecture, what I would really like to do is basically tell you that there are a vast number of varieties, lengths, utilizations of different hand files. And when you get into really the weeds of hand files, there's so much you can do with hand files to a really fine, specific control that you don't have just with rotary files. So just taking one example of the files in front of you, at the bottom of the picture, it says RT files. Those RT files are intended to cut more aggressively than a regular K file. And the D finders are stiffer than a K file. So for calcified canals, curved canals, those are really wonderful instruments that duplicate the use of a carbon steel file. I pre-curve all of my hand files every time before I enter them in a canal, and that has real value for me. I want to talk really briefly about 3 motors because it's really important that we have visual and tactile control, and part of the tactile control is the predictability, reliability, the auto reverse function on our motors. So I want to focus on 3 motors, the NLZE micromotor, the Endomate TC2, and the DT. I will say, again, no commercial affection here, that there are a lot of motors on the market. Aseptico has a wide range. Comet has the EndoPilot. Dentsply has the ProMark. I really like the NSKs. On the cordless unit on the left, the beauty is this is compact, inexpensive, it's portable, it's rechargeable. There are a vast number of different heads that you can put on the handpiece, from mini heads to larger heads that can adapt an apex locator. And we have that same functionality in a slightly larger unit in the DT. And that just has slightly, in my hands, just a little bit more torque than the cordless. But both of these are excellent rotary motors for the indication, and the quality at NSK is very, very high. I really like these motors. They're not cheap motors. This is a really high quality product. Now, I'm a huge fan of the NLZE because this has 3 things built into it. It has a lot of things built into it, but one of them is that with the touch of a button, you can use this in reciprocation for the Wave 1 system. And I use the Wave 1 system. So if you're using a counterclockwise reciprocating system, this is a really beautiful, elegant solution because literally you have one handpiece, you change the head and you can do your endo, put your high-speed head on, you can do your high-speed cutting, you put your slow speed on, you do your slow speed work, you can vary the rotational speed, you can vary the torque. This has a built-in sort of a heat check in it to make sure that the motor is operating functionally and correctly before you start the process. And this has it's plugged into your unit. It's small, it's portable, it's compact, and it's not particularly expensive. So I think it's a really powerful system that gives you the best bang for the buck from an endodontic / restorative standpoint. And I like Wave 1 Gold a lot. I've lectured on all kinds of rotary systems around the world, and I've been involved in the rotary universe for probably 2 decades now. And to me, this is the safest, most reliable, efficient system that I have run across. I really like this. So to put it into slightly different terms, the vast majority of my cases are going to be finished with the red primary size. And generally, once you have a glide path and you've pre-flared the canals and you've got the right coronal access, and you have the sort of the correct conditions, this meaning the glide path, this red file will go to length very quickly. So we're almost done. We got just a few more slides and we'll wrap up and go to questions. I want to talk briefly about bioceramic sealers. We did not talk about this 2 weeks ago. So they are biocompatible, non-toxic, they're chemically stable, they don't shrink, and they form hydroxyapatite when they set, and that creates a bond between our dentin and our GP, even with moisture. They're antibacterial, and the literature argues that they seal quite well. So these are calcium silicate based, and the sealer penetrates into the tubules irrespective of the obturation technique based on this article from 2017. When you look at that surface of the tooth, you can see that the canal is full of sealer and there is one cone. So this represents a slightly different obturation technique from a warm vertical technique or a lateral condensation technique. I want to be very clear that we absolutely have to be really, really careful to know exactly how much sealer we're putting in the canal, where it is going, what pressure we're using. I want to emphasize this, not to ever lock this needle into a canal, because we can easily, given the viscosity of these sealers, we can easily put this material beyond the apex. So here are 2 examples of sealers. Brasseler has bioceramic sealer, but there are less expensive options. These are 2 of them, one's from Diadent, one's from Meta. And in terms of activation irrigation, I mentioned that a little bit earlier. This is a sonic device. Dentsply has the endo activator, which it would be a comparable product. This oscillates at a sonic speed. So we're putting this little plastic tip into the canal and moving that up and down, which creates a sonic activation of our irrigation. Here would be 2 other options. One would be the Edge Pro laser and the other being the Gentle Wave. And I believe that to be the accurate price per handpiece. Please, that's what I understand commercially. We're in that ballpark. Maybe the handpiece is a little less expensive if you buy them in bulk, but essentially these are ways of activating your irrigation. And in Gentle Wave jargon, that would be ultra cleaning the canals. So here's my final thoughts, and we'll wrap up, get to your questions. We always must duplicate the chief complaint, never depend solely on the radiograph, and we want to rule out non-odontogenic pain and TMD before we say, yes, this is an odontogenic problem. So that is more of a blue moon, the non-odontogenic universe. But we just want to be sure that we're going to solve an endodontic problem, a dental tooth-related problem, by doing the root canal. So I want to say thank you for tuning in. I got great feedback from the last lecture. It's really an honor to be on Viva Learning. I really appreciate your tuning in and being a part of this. There is my contact information. So if you would like to contact me, you can feel free to give me a shout. And let me see, I'm going to go to the questions. Okay, besides second molars, what other teeth do we need CBCT for? All of them is the answer. It just depends on what's there. You know, if you had number 8 and it's got resorption, you need to know, is it external? Is it internal? Does it perforate the buccal? Does it perforate the lingual? When you need it, you need it. And it's not just a second molar thing. In teeth with previous large restorations and a need for a crown who respond with thin normal limits to pre-op vitality tests, may become hypersensitive after crowns are cemented. What could be the reason? What's the best way to advise the patient? Sometimes they don't expect to get a root canal. I think I would tell everybody who gets any filling any time, no matter how invasive or non-invasive that filling, that a root canal is potentially an outcome of doing that treatment. And let's assume, for the sake of argument, that a tooth is having a crown. I think it's worth telling the patient that 1 out of 5 teeth that we treat ultimately ends up having a root canal, because that's essentially what the literature would say. So to answer your question, even though there may not be overt symptoms or anything in the testing or the radiographs, the odds are about 1 in 5 is going to end up with an endo. And I think it's better we just tell patients up front that, you know, it is a possibility. So to give you a more well-scoped, well-rounded answer, we want to know the pulpal status before we start. And we want to really take a sober look at that tooth. And we want to tell the patient it's always a risk, and then give them kind of the odds. And then if it goes south, they need a root canal, you've told them about it. For hot lower molars, are your blocks IAN or GAU? And is one more effective than the other? That's a great question. These are all great questions. It can be a GAU. It could be an Akinosi. It depends is the answer. And I generally don't go to the GAU or the Akinosi unless I really need it. And I don't end up doing the X-tip, the intraosseous, very often. If BC sealers past the apex, would it not resorb over time? And that's a really great question, and it takes a little bit of a nuanced answer. It depends on the tooth. It depends on the anatomy of the apex. It depends on what vital anatomic structures are around the apex, and the quantity of sealer, the type of sealer, the formulation of the sealer, the viscosity of the sealer, how much pressure was put on that. All of those things are going to make a significant difference. So to answer your question a slightly different way, if you put some sealer beyond the tooth and it is not in a strategic vital area, realistically over time it will be resorbed. But if you poured a certain degree of sealer into the mandibular canal, and let's say hypothetically you have irritated the inferior alveolar nerve with your instrumentation techniques because you didn't have the right working length, you could be in enormous trouble. And I can't quote the exact date of the paper, but there was a JOE paper where there was a permanent alteration in the sensation of the mandibular nerve with what looked like a very minor amount of sealer extrusion. But I'm looking at a malpractice case right now that I'm an expert on, where the way that the mandibular canal traversed to the buccal of the tooth is really unusual. And so if you're only working with 2D pictures, you really don't know where that canal is. And then, if you put just the wrong amount of sealer beyond the tooth, you could potentially damage that tooth irreversibly. So that's the best answer that I can give you. But hey, I really appreciate everybody being a part of tonight, and feel free to contact me anytime. And I wish you all the best in your endodontics, and good luck.